Good afternoon, and welcome to the SP2 Speaker Series. This is our first for the spring semester, and I'm excited to introduce to you all today Dr. Ahmaad Jenkins. Dr. Jenkins is a Vice-Provost Postdoctoral Fellow in the School of Social Policy and Practice. He also is a Leonard Davis Institute of Health Economics Associate Fellow, as well as a lecturer in the Department of Biobehavioral Health Sciences within the School of Nursing. Dr. Jenkins is a dynamic speaker and scholar, and I'll even give a fun fact in a little bit about Dr. Jenkins on his public speaking experience. But he earned his PhD in sociology and criminology and law from the University of Florida. His work examines the influence of race, racism, and law within medicine. Using critical race theory, Dr. Jenkins is currently working on 3 book projects. 1, Hue Process, the quantitative measurement of racism in medicine. 2, Refund My Freedom, how the law created health inequity in the Black community. And 3, Branding Jezebel, Black women, law, and medicine in antebellum America. So those fun facts that I wanted to share. 1, and correct me if I get this wrong, but so Dr. Jenkins was the announcer for the North Carolina lottery system. And two, for all those baseball fans, he was the announcer, or one of the announcers at least, for the Durham Bulls minor league baseball team. Today he will be sharing his work titled Chasing the Boogieman, Race, Racism, and Critical Methodologies in Medicine. And without further ado.
Thank you, sir. So it's always funny when people hear about this lottery thing. So every night at 11:22, ladies and gentlemen, good evening. My name is Kevin Jenkins, along with our auditor from Thomas & Gibbs. Last night, so I used to do that every night. And I'm no exaggeration. We did the Merry Millionaire Lottery. That was my last time doing it. I literally stood there. They had a script for me, and they called me One Take Willie because I knew how to do it in one take. So really what was going on was I got tired of the scripts. I got tired of feeling like every time I was speaking, it was like this moment of like, you know, they don't think there's any depth to you because you're just jumping around and doing entertainment stuff. So that's when I quit all my jobs and decided I wanted to be smart and get a PhD. So here I am. I guess it worked, right? So I want to give a couple of disclaimers for today. The first disclaimer is I have an extremely bad back today. All right, so you may see me kind of moving a little funny. So if you see me grimace, don't worry. But this is maybe the only thing that keeps me standing in place, as any other time I'm walking all around the room. The second thing that I want to tell you is that we're going to go through pretty much heavy statistical stuff at certain points, right? So I'll make it as painless as possible. But one of the things about this talk that I think is so important is it shares with you my journey to doing what I'm doing. Arguably, I'm a historian, bachelor's and master's in history, started out in health services research with my PhD, ended up finishing in sociology. So when people see me and they see all the work I'm doing, they kind of get confused. So I want to take you on that journey and make it a little less painful as I had to deal with it. But I want to make it to where you can understand kind of where we're going. So with that, I'm going to ask Erica Garner to kind of help me to do this.
Look at Khalid Browder's mother. Right. She died of a broken heart. She had heart problems because she kept on fighting for her son. Like I'm struggling right now with the stress and everything or whatever, because this thing it beats you down. The system beats you down to where you can't win. When you ready to, you know what, I'm going to take this money, just forget about it. No, my father would not be forgiven. My father, he died. He died on national TV. I had to see him die on national TV. A lot of people don't get to see their parents die. Don't know why. They just go on and, you don't get to say goodbye. But I felt the same pain that my father felt on that day when he was screaming, I can't breathe. When he was saying that he was tired of being harassed, tired of freaking being arrested, his money being stolen from him. And he was spreading like, I'm not giving up and this is the fight. I'm in this fight forever.
Her forever came on Christmas in 2017. Her autopsy suggested that her death was due to asthma and more than likely obesity. However, many argue that she died due to the stress of systemic racism. She died due to watching her father die on television. She died due to watching his killers go free. Accordingly, researchers may statistically categorize her death as asthma related, but the metaphysics of this tells me that it's something a tad deeper. I can't breathe. So when I put this presentation together, I've been really ruminating on this idea of stress. And I remember when Dean Jackson sent me the email, like, you want to do this? I'm like, yes. But I didn't know the beginning would take such an interesting turn. I can't breathe. Her father also had asthma, but that didn't kill him. I can't breathe. She has a 5-year-old that will now grow up without grandfather, now mother. I can't breathe. So when we think about statistics and how they're racialized, we hit a certain point where how interesting. Hot off the presses. As Ezekiel Dixon Roman talks about in his book, he talks about the way that we're approaching these statistics and this idea that as a result of its almost a theoretical lens, the positive approach, this positive orientation tends to interpretively misrecognize the underlying structural relations of the data, often falling into the trap of pathology, deficiency, depravity, narratives of the marginalized. I can't breathe. So we ask the question, does race matter? When you look at this idea of statistics, we see black men spiking largely in the orange. This is mortality rate stratified by race and gender of diabetes from 1980 to 2008. What we're seeing is a pattern and a trend that even though things are reducing, we still see a disparity. We can look at that same disparity when we're talking about mortality rates per 100,000 when it comes to heart disease, cancer, and diabetes. We see the same statistics, and the question has always been, well, what's wrong with them and not what's wrong with us? I can't breathe. So we're trying to get into this moment and understand exactly what are the statistics really telling us. But also, I think it's about what the researchers are telling us, right? So I think that's why we have to have researchers that are more oriented to this lens of critical methodology, because as we ask the question often in another talk that I always do, I always ask, does race matter? But really, the question is, does racism matter, right? These are little small nuances that even in medicine, when we're talking about race, we really mean racism often, right? And we're getting ourselves to a certain point where often we racialize the statistics that you just saw as a point of deficiency on the patient. They're not taking care of themselves. They don't eat right. But then we forget about the other side of it, that there's a systemic issue that's holding folks back from achieving optimal health. So how do we find ways to measure injustice? Kamara Jones talks about it in great detail in her article, Levels of Racism. She's been one of those people that's been a stalwart for me, even in the work that I'm doing. I've had a lot of opportunities to sit and chat with her. And the one thing that I tell her every time I see her is thank you, because you corroborated this little voice that I had. Because as a scholar, we have to be, being a scholar means you're a snitch, right? Because you can't say I said it. It's according to, right? You got to have all the according tos. So, the thing that hurts is when you're doing this kind of work, you got to find somebody that in the scholarship has said what you're trying to say. And that was my hard part. She said about racism that it's about structuring opportunity, assigning value, watch this, based on social interpretation of one's looks. We didn't say skin, one's looks. that creates an unfair disadvantage for some individuals and communities, unfairly advantaging other individuals and communities. And it comes at 3 different levels. See, most people say I'm not racist and just call it a day. But it's 3 different levels of this thing, right? It's institutional. It's the boogeyman. It's those things that we can't really touch. It's often those things we can't see. Then it's the personally mediated. Those encounters that we talk about quite often are actually the ones that everybody defaults to say that I don't do that, right? But then the internalized racism, this is a space that I still struggle with. I have to put it there because that's what the literature talks about. Again, it's not one that I can say I wholeheartedly can keep diving into. I think it needs more interpretation, but it's really beckoning the question that when we continue to absorb the racialized spaces and the racialized statistics and meeting patients that say I'm sick because I'm black, that becomes problematic to me because these are real conversations that we have whereby they don't think they can avoid it. So then we hop over across the street to Thicker Than Blood, according to Professor Zubiri's work, where he talks about the story of racial statistics. And he's really arguing that we got to start thinking about how these numbers lie. How if you can change or take out a variable or insert something else or give a little more weight some way to another space, you can tell a whole different story. David Williams goes a little bit further when he, in a systemic review that he and Williams and Muhammad had put out in 2009, where they talk about the careful reassessment of our current approaches to the study of discrimination and health particularly. So I want to just make this caveat. I don't believe in saying unconscious bias. I believe in calling a spade, and if it's racism, and I'm not going to hide behind the words. And now that gets me in trouble quite a lot. But the truth is, many people, I remember even defending my dissertation when they said, well, you're talking about racism, so are you saying that all doctors are racist? And I said, that's not actually what I said, but I said there are a lot of doctors that are racist. Everybody in the room paused because no one's really used to talking the way we need to talk to get the kind of equity that we need. I'm not going to dance around the moment. When we think about the impact of racism from a health perspective, what we see is a biosocial effect. Poorer health outcomes across the board. You see a psychosocial effect when it comes down to the mental health. Not talking just simply about psychosis, but talking about also the idea of stress, right? You heard Erica Garner talking about stress. The social behavioral, what a lot of people that come from vulnerable communities have to do. Dr. Har Feldman, he's one of the mentors I've been working with over in the School of Medicine, and we were talking about this one day, and I remember him leaning back in the chair, and he said, well, what about just the fact that so many people from these vulnerable communities have to get themselves up and get ready to deal with the isms of their day, right? There's some days you don't care. There's some days somebody can say something to you that just is rude and you're smiling and you're like, you aren't gonna ruin my day, right? And then there's some days where it could be something so small, so insignificant. Remember these words, something so inconsequential, remember that word, because that's that breaking point for you. And we dismiss that. So the question is, how do we measure it? Clark et al. Put out an amazing article around 99 to talk about racism as a stressor for African Americans, to really be able to start pushing a biopsychosocial model of stress induced by racism. And this was the article that literally changed my research. It changed my books a lot, because it made me start realizing that we have to speak the clinical language as much as we speak our social science-y language, right? We have to be able to sit within both worlds, and it really made me reassess everything I was doing. It made me go back and literally delete 7 papers and start from scratch. So you get to see, I think, 4 of them today, and they're really easy to navigate, but it brought me to my own biopsychosocial model, and this is specific to more chronic kidney disease, but I'll talk more broadly about some of the other things that we've seen within this biopsychosocial model and some of the papers that we've been working on. So really the main thing I want you to gather from this is we know there's a relationship between race and disease, right? That's pretty flat out. Everybody says it's disparities. And when I'm talking about disease, I'm talking about heart disease, I'm talking about asthma, I'm talking about chronic kidney disease, diabetes. So as we look at these, most folks start looking and diving deeper into the socio-demographics and how that spells out in this space. A lot of people have defaulted to the biologic issues and genetic issues. They're not one word, they're not interchangeable. So it's easy to default here and here because now we can brand deficient patients. Right? There's nothing I can do because, genetically you're predisposed. Well, I mean, when you come from lower income communities, so we play the class argument, right? We hit William Julius Wilson where we're talking about the declining significance of race. So we often forget about this idea of stress, particularly not simply stress, but psychosocial stress, the stuff that's caused by environment. And what we've seen through the literature is that we've seen that physiologically psychosocial stress has been embodied through 3 different spaces, right? Through heart disease, cortisol, blood pressure is also one of those more tangible spaces. But look at those psychological questionnaires, right? And all these different batteries of tests. But the question is, are they specific to issues of race and stress? So we'll get there. So let's talk about the physiologic pathways of psychosocial stress. So one of my students for this summer with the LDI SUMAR program, we had a great opportunity to work with students from literally all over the country. And one of them, she's right here from Philadelphia, a senior now at Cheney University, Markia Menifee. And she came up with this amazing thing. So I sat them, we were literally sitting in this room, and we were working on everything for their final presentation. And I said, I don't want you to be lazy. Push yourself to think about how to explain psychosocial stress to your grandmother, right? We don't care about how smart you are, break it down. So Markia is the quietest, just really, she is brilliant, mind you. She's just so brilliant, but she's just so quiet. And I told her, I said, that ain't gonna work in this lab. You're gonna have to talk. She's looking at me like, but I don't, by the end of this lab, she does this. So she comes in and she stands right here at this podium. I'm so serious. We were literally in this room. She stands at the podium and we're practicing. And she says, when I think about psychosocial stress at this level, I was shocked because she never talked this loud. I think of it as tennis practice. And imagine the tennis machine. And we're all used to one ball coming out, right? Right? Another ball come out, right? She was like, what happens if the machine breaks? And you got all the little tennis balls coming at you at one time, right? That's psychosocial stress. I said, oh my gosh, you did it, right? When we think about the idea of psychosocial stress, our body is equipped to handle 1, maybe even 2, you could handle that. But at heightened levels, psychosocial stress puts a severe burden on your body. So what we see is how it impacts us at different spaces, different systems, from the liver to the kidneys, which is really one of the main mitigators of stress in your body, your GI tract, your lungs, the cardiovascular system, obviously neurological function. People forget a lot of stuff when you start getting stressed out. You start doing the stutter moments and stuff like that. When you think about, obviously heart rate is attached to this, but the question is, how do we link the ideas of what physiologically is going on to the social? That's what makes this difficult. So psychosocial stress, as defined by Lazarus and Folkman, gives us an opportunity to talk about social threat. Social threat is often theorized as this idea of feeling helpless, right? So it refers to a person's cognitive recognition of an attenuative response to social threat. So you gotta know it's a threat, and then how do you deal with it, right? And there comes a point where psychosocial stress hits you at a moment where you see it, but you can't do anything about it. Therefore, you feel helpless, right? So in the literature, it's really weird because they have some real troubles. This has been going on for 30, 40 years. So I'm just throwing my hat into it now, where we're trying to really give the definition of psychosocial stress. It's a hard one. you know, but often it gets set up to talk just about whether people change their mood, right? Are you sad? But here's the thing about racism induced stress. It is what it is. I know a lot of people just how we feel about it. It's just like, I saw you cross the street when I started walking your way. Some days I get mad about it. It may stress you out a little bit. I know that you didn't talk to me when I was in the store. You talked to someone else. I know that you yanked your purse when I walked up. I know, but it doesn't make me sad. It's not something that you see in a mood or behavior sometimes, and then sometimes it just comes out of nowhere. So these are the things that we have to start diving deeper into, because what we also know is that we look at the problem-oriented approach or the resource-oriented approach. So basically, where is it coming from, what's causing it, the problem-oriented, or resource-oriented, how much stuff do you have so it doesn't matter? So this goes to social support systems and having real conversations about psychosocial stress and how to respond. Whenever I do a lecture on race and particularly racism, the thing that I always ask the crowd or students, whomever, is when's your first experience that you can remember with some issue of ism? And my second question is, how did you respond? Most of the people in the room, often on the first go round, say, I was so shocked I didn't even do anything. Because, you know, I love hearing those folks that are like, you call me, I'm gonna knock you out. That's what's up. You know, I appreciate your valor. Thank you, but I got a job. You know, I'm not swinging on nobody, but, you know, I might flinch at you, but that's about as much I'm gonna do to you, because I like where I work now. You know, so my bills don't care about the honor of my people, right? So we have to remember that. So Clark et al. Talks a lot about this exposure to detrimental environmental stimuli. So I tried to find a way to jump into this empirically. So this is where we get a little into it, right? So the thing that I was trying to understand is this idea of psychosocial stress. I was trying to understand how it translates to different disease outcomes, and even can we translate some things to racism? So I was like, I don't know, let's find out. So what we did is use the CDC behavioral risk factor surveillance system data. Look, let me go back, sorry about that. Sometimes you get fancy on you. So it's an annual survey focused on health, medical behaviors, and outcomes. One of the big things that I really appreciated about this, it does include some limited child data, not a lot, but it includes enough stuff to where you can get some interesting questions off. A lot of those child questions are centered around asthma. Random digit dial of residents, so you know there's often, they try to do some adjustments with cell phone use and stuff like that. So it's still some nuances to this data that you see over time, but I pulled it from 2004 to 2013. It uniquely asks health and healthcare questions concerning kidney disease, diabetes, heart disease, asthma, and so much more. So if you have interest in this type of data, it's free, it's available. All you gotta do is just go to CDC website and download it. It captures psychosocial stress in a 30-day period, and it asks a very unique question that was put there by Kamara Jones when she was working with them on this, where she asked the question of how do other people classify you in this country, where that's really asking how do people observe you? What's your perceived race? So all of that matters. All right, so let's get into the first one. So this first paper is explicitly focused on these different spaces. So across the papers, I just want to kind of give you the covariate setup and kind of what we did in these, so that way I don't have to keep saying the same thing. So I'll get faster as we get through them. If you have questions, please feel free to just save them to the end, so that way I can at least get through it for those who may have to step out a little early. So we use the appropriate bivariate test of significance. Because of the heavy overdispersion issues that we had in this data, we had to use a quasi-likelihood Poisson model as well as negative binomial models to correct for the extensive overdispersion. Overdispersion is nothing more than when your variance is bigger than the mean. Shared covariates across the papers and models included the following. We did demographics such as age, sex, marital status, insurance, and income. It's really class, but sorry about that. Health stuff, with self-reported health status, BMI, and depression diagnosis. You cannot measure stress and not adjust for depression or in other clinical measures. You cannot do that. So if you ever see somebody with a paper that has anything about something with stress and they do not model or adjust for anything dealing with some kind of clinical diagnosis of some kind of issues, ding, 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 okay? So just remember that. We did we weighted the results with the pooled adjustment. So essentially when you have weights on pooled years, you basically take the weight and divide it by the number of years. So I'm just telling you that. So that's stuff that a lot of times when we get into the data, this is an approach used a lot in the NHANES data. And we use this approach. There's really no big difference between not doing it and doing it, but we just did it because I think a lot of the research more or less supports doing it this way. Yes?
Just a clarifying question, did you not have education?
We did have education. So within the CDC data, this is one of the things. So we actually, in some spaces, we would include it. And in one of the studies, I'll tell you, it heavily conflicts. So a lot of people are more willing to answer the income question versus the education question, which is an interesting space. So because you have a lot of missingness in education, we actually had to, in a couple of the papers, we had to drop education out, yeah. So, and I'll show where that happened, and you'll understand why exactly I did that. But it's included in 2 of the pieces that I'll show you, and then the last one is not included for that very reason. We lost a lot of sample using education. So the first paper is I Can't Breathe, the cross-sectional analysis of race, stress, and asthma. How is the relationship, the relationship between race and stress moderated by asthma, right? So really, I was trying to, situate the idea of a binary space of race between the white-black binary and asking the question, do black folks have more psychosocial stress than whites? And then when I add in the idea of asthma, do we see a moderation effect that happens with that chronic disease state, right? Do you see more asthma issues or whatever between them? And is it further moderated by the fact that we have race in there? So that's pretty much where we are. So the first hypothesis here was that blacks without asthma would encounter more stress than whites without asthma. Second hypothesis, respondents living with asthma will experience more psychosocial stress than those without asthma, regardless of race. And then that third one is the big one that we've been looking at, is that blacks with asthma will encounter more psychosocial stress than whites with asthma, all right? So if you look at these hypotheses, the next study is literally the same thing, just swap out asthma and say CKD, chronic kidney disease. We had about 1.2 million and some change for our analytic sample. As you see, this is a pretty, so my dings, I've gotten a lot of rejections. Y'all don't understand, them things hurt. Got a lot of rejections because of sample size issues, right? So I said, you know what, I got you. This is what I'm gonna do. I'm gonna just redo everything and put the biggest samples I can get and go for the biggest, broadest ways to attack this very same issue. So that's what I did. We went back to the drawing board. I said, I don't wanna look at another rejection. So I know these are hot, right? I know it. Feel like you're dropping an album when you're a scholar, right? You're just like, this is a good song. Nobody's voting for it, right? So, you know, again, you see a pretty good sample here. We use negative binomial regression on this one just because there's a count fit space, a count fit post-estimation command in Stata will save you so much time. Because all you literally have to do is run count fit and it runs your model to Poisson, negative binomial, zero inflated. You can do a bunch of different measures and you get all the statistics at one time and it tells you what the best model is. So based on the count fit post-estimation, negative binomial regression was the best. We still had some issues with over dispersion, so we corrected it using the quasi-likelihood model, okay? And the outcome in this space is the number of psychosocial stress days in a 30-day period. So it's count, hence the reason we're using a negative binomial. I won't go through too much of this if we want to come back and revisit, but I just want to zero in right here because really what we're seeing is that blacks with asthma are encountering psychosocial stress at higher rates, but I think it looks a lot better to show it to you this way in predicted probability. So the predicted probability, this is here on your y-axis are the predicted mean days of psychosocial stress. we're looking at this over age on your x-axis, right? And these represent, again, the probability at the mean space for these respective ages. This line here reflects blacks that are living with asthma. This line, interestingly enough, reflects blacks that do not have asthma. This line are whites with asthma. It's something very interesting about the idea that black folks that do not even have asthma experience almost a very similar trajectory of predicted probability of stress as whites with asthma. And blacks with asthma are experiencing a statistically significantly higher space of psychosocial stress. So the next study looked at CKD, very much the same setup, so I can kind of go a little bit faster unless you have some questions on that space. But here we looked at chronic kidney disease. We had about, a little over 1 million folks in this sample, but once you start getting into the weeds, what we wanted to do was look at veterans, particularly vets with chronic kidney disease, and compare them to a general, quote unquote, kind of healthy population without the CKD. I wanted to see what it was, right? The reason why is because often when it comes to vet status, many people assume that you're a veteran, you have access to all of this stuff. There's a lot of papers that come out talking about how the VA has reduced discrimination and racism experiences and all these kinds of things, but accounting for the medical space only doesn't account for all of the other things that happen outside of the medical center. And I think that's some of the things about measuring stress that can help us get closer to how stress gets in you, how we embody this idea of psychosocial stress. So again, negative binomial regression, same outcome, same adjustment with the quasi-likelihood model correction. So very interesting space. So again, we see the incident rate ratio telling us that there is a statistically significant difference. It really is statistically significant amongst all spaces. Like pretty much the effect for blacks without CKD is not, too huge or anything like that, but it's certainly a statistically significantly different effect of psychosocial stress among blacks without chronic kidney disease. But white veterans with CKD certainly experienced higher levels of stress. But again, blacks had the highest levels who are veterans with CKD. So here it is in predicted probability, right? So same chart. So I don't know why I like this little green line. I started playing around with the colors, and I don't know. I just, don't ding me on the color, but it was like whatever. So if we see here again, black veterans with CKD have the highest predicted probability over age. You see overall an effect of stress reducing, even in the last slide, you see overall that stress in itself reduces as you get older. Because I think folks just start learning how to deal with stuff, right? That's just another fact of life. My mom says if it's still bothering you, live a little longer. That's what my mom always said. So, we still see this. This is some compelling evidence to start talking about just the role. We don't know directionally is the stress because of other stuff, because it's cross-sectional data. So we can't say, causality and all of that. But what we can say is there's certainly an association between race, chronic disease, and stress. We can say that, undoubtedly, right? So that gets us into this idea of race. Oh, I'm sorry. Oh, here is black veterans with chronic kidney disease. And then here are white veterans with chronic kidney disease. And the funky color line are blacks without kidney disease, and whites without kidney disease is a solid black line. Well, yes, it's still consistent, but just, you're not seeing, particularly those who are black without chronic kidney disease, they're certainly kind of miles away, from those. CKD is a hard very interdependent disease. You know, it's just one of those things where you can't do for yourself. So you should definitely see more stress, and it's consistent with all of the literature. Particularly Levy has put out a lot of work on this idea of psychosocial stress amongst chronic kidney disease patients. They have literally a 50 times higher rate of suicide compared to populations that do not have CKD. So I think that's a really important space just for myself. And I'll explain a little bit of that at the end. So I'm almost done, believe it or not. I've shortened my slides because often my presentations get to the point where I'm like running out the door in 45 minutes. So getting to this idea and concept of race, it goes back again, the same type of definition Kamara Jones used, and we see Dorothy Roberts doing the same space. The invented rules, the physical features, the social clues. So the question is, you remember those studies where you had like Jamal and Michael, and you send the CV in and see who gets the job, or the study that tells you like send a black couple in and a white couple to see if they'll lease the apartment. And I was like, what if we could do something like that in health? And everybody thought I was crazy again, because that's just how it works, because you can't do stuff without the data, right? So this is what I worked on with my dissertation work that we're finally moving forward on. But when you see him, is he white or black? White? Yeah. Anybody else want to weigh in? Latino.
Mistake? I don't see race.
We come in all shades.
Exactly.
Yes.
I really thought you were a white guy. My apologies.
That's all right.
Or congratulations. However you see it, it's not for me.
I faced it for 66 years.
Okay.
Badge of honor.
Excellent. Excellent.
Congressman G.K. Butterfield, he's formerly the head of the Congressional Black Caucus. These are his biological parents. He looks just like his mom. He just happened to be really, 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 really light, right? So my freshman year at North Carolina Central University, they said they're gonna have some preeminent speaker come and speak, a great alum of NCCU and this great powerful black man, he's a judge, and he walked in. And I was sitting in the back like, who's this white dude? Like, like we all sit back there like, you said he was black, like who is this guy? And then he started talking and everybody was like, no way, right? So it was that weird moment where you start getting into that space, because that in itself is about how we recognize race. You know, so even if you pass a skin test or don't pass a skin test, the next thing we're saying is like, say something. Let me hear something, anything, right? So we think about race in so many different ways, so many different spaces. So we think about this idea of what I call racial incongruence, where there are people who self-identify one way but are perceived as another. So what does that even mean? How do we look at it? You know, we see these, like this is my ex-girlfriend's grandmother. Now here I would say like Latino, you know, something. When I was younger, I first walked in the house and I was like, your grandma white, but that's cool. And then she started talking and I was like, no, she's not. I'm confused. And I see her family tree and it's like, we were together 5 years. So we went to the like family reunions and you go to they knew I was not in the family. But at the family reunion, you would see white folks at the family reunion. They're like, yeah, this is my cousin, da-da-da-da. So it's really weird, right? So the next time I do this presentation, I hadn't been able to update it just yet, but Amanda Washington Lockett, she's a student over in GSC. Booker T. Washington Lockett, Booker T. Washington is her great-great-grandfather. Crazy thing is, if you see her dad looks kind of like this guy here. But he looks just like Booker T. It is scary to look at her father. There's a picture she showed me, and once she sends it to me, I'm gonna put it in the presentation. It is scary, right? So when she first heard about my research, we talked for forever, because I was like, well, y'all gotta give me permission to use this stuff, because I don't want you coming after me, right? And many people think when I'm doing this kind of work, I'm talking about just light-skinned people or fair-skinned folks. And we look at these 3 black women, like, most people just wanna hone in on the colorism issue, right? That's all people think I'm talking about. But I'm literally talking about the fact that, you know, I wanna go against this idea of colorism where she's gonna experience a different world because she's lighter. Because that's what we talk about, you know? But won't I mess you up if I told you that she's actually a white woman? So I know her too. Went to the University of Florida. We were at a party. It was fun. So I ain't had no game back then. I probably still don't. So I just literally walk up to her and I say, hey, put your number in my phone. And I walked off. It sounded good. It felt right. You know, we talked on the phone for a week. And then she lived a little further out of Gainesville. So she lived in Altamont Springs, which is right outside Orlando. And they got this big mall over there. So we meet up at the mall. She was like running late, so she called me like, hey, where are you? I was in H&M. Now I guess I'll never go to H&M again. I couldn't fit anything in there anyway, but you know, anyway, so I'm in H&M just killing time. And next thing you know, she calls, says, hey, I'm here, where are you? And then all of a sudden someone walks up on, I didn't see her, someone walked up on me. She had straightened her hair and she looked like a totally different, no exaggeration, she looked like a totally different person. And she started laughing when she saw my face. And I was like, and she was like, I know what you're thinking, right? And it's this moment where she says, I get it all the time. People think I look black, or then they think I'm trying to look black, all this kind of stuff. And we started talking. So you missed the nuance. She and I talked for a week. Nothing raised the flag. Why? Because academically, we're not allowed to say someone sounds white or black and all that kind of stuff, because we're like, no, we are smarter than that. But the truth is, these are our social clues that we use often. So I asked a question in my research using the CDC data with that how do people classify you question. And I looked at people who self-identified one way, but their perceived race or their classification status was different in how they were perceived. And particularly, I modeled it only looking at self-identified whites compared to how they're perceived. All right? So we literally asked the question in a way of this. You're racially congruent if you're white and look white. You're racially incongruent, and this is the space, so your mind doesn't explode. That's why I had to show pictures before I talk about it. So you're racially incongruent if you're white and are perceived as black. But then there's another category that I created because the cell sizes get way too small when you start including all the other things. So I really wanted to understand, is this an effect of not looking white or an effect of looking black, right? So we added a third category of whites who do not look white or black, all right? So the first thing that we find, and I'm not gonna go through the actual numbers on this one, I'll be happy to share and talk about it a little further, but I just wanna get toward the end here. The first thing I wanna show you is just looking at income levels, where this is the highest. So basically the income goes, you know, from, what is this, y'all's right? Yeah, right to left, the income reduces, right? The income levels, right? So the highest level here is more than 75,000 and the lowest level here is less than 10,000. What's the immediate thing that you see for whites who clearly look white compared to whites who look black and whites who don't look black or white? Yeah. So it just beckons that question. It's kind of weird, like it's statistically significant in the model, but it beckons that question like, you know, is there some kind of effect of not being able to tap into the privilege of looking white? So when we looked at psychosocial stress, again, stratified by perceived race, predicted probability of predicted mean days of stress is the Y, and it imputed age category. For whatever reason, they get weird in 2013, where they don't actually ask age continuously in some other years, so we had to use the imputed age categories to show this. But nonetheless, this is the line with whites who are perceived as black and their predicted probability of psychosocial stress. This is the line for whites who are not perceived as black or white. And look at this. That's the line for whites who clearly are seen as white. So when I sent this paper to JAMA, because I was like, this is important, y'all need to publish it, I actually, in a weird, they rejected me nicely. They're like, it's like, you know, when you ask somebody, you know, to go out, and they're like, no, but you're cute, right? They gave me that. So they actually put in the notes. They told me, they said, listen, you know, sample size is small for us. So what we have for whites who look black, we only had 94 people, right? So that's already an issue, right? That most people are like, no, that's not enough. But what it's still telling us is we're meeting that threshold. We had over 1,000 and some change for whites who don't look black or white. But, and you know, of course we had more than enough, but we're still able to prove statistical significance. We're still able to meet those statistical thresholds. So, you know, I'm gonna have to go to obviously some lower journals because it got rejected by like 3 of the top journals. So now I'm like, all right, we got to get this thing out. So, you know, but in looking at this, this is at least telling. This is giving us a launch pad to talk about what happens that racism can be so powerful that you don't even have to self-identify as black to be treated, quote unquote, accordingly. So Renee Bowser had a powerful quote in her paper where she talked about the biomedical professions. And she said that the biomedical professions, academic disciplines, and medical practices reproduce and legitimate biological and ideological mythologies about black patients. So when so many providers go into a setting, they're going in with a perceived notion of what they are or are not. And I believe those perceived notions are dangerous. For one, because you could have folks like G.K. Butterfield. But for two, we're not accounting in that setting for all of the other things that go on in this world that they bring into that clinical environment. There was a paper that came out in Science with Michael Udell, Dorothy Roberts, Rob DeSalle, and Sarah Tiskoff right here at Penn, talking about really taking race out of human genetics. And, you know, a lot of people took this paper and ran with it. They said, oh, yeah, we don't want to talk about race. And that's not really what they're saying. They're saying that we need to look at race way differently because we're thinking about race with those perceived notions, social clues, those kinds of things. But I do believe there's a utility in keeping race as it is, as we know it, in our field of study. And the number one reason why is if we don't put race in there, racists get off the hook. We have to put more research into ancestry and understanding what ancestry means. Because really what they're asking is who are your people and where are they from, right? Because there's a big difference when your people are from the Caribbean or being from Florida like my folks are, right? It's just a big difference. Like, I won't go into that part, but I want to stay on task here. But I believe that what we have to do is dive deeper into ancestry. Instead of just saying we need ancestry, ancestry is quite like psychosocial stress. They're still trying to find better ways to operationalize it. And that's something that we have to keep working on. There is a utility, there is a nuance in identity, my race, ancestry sometimes, most times, but really my ancestry. There's a difference in identity versus identification. How people identify me could kill me in some spaces, right? How I identify has some latence of medical issues and things like that. My dad's mom died of kidney disease. She had diabetic kidney issues. My mom was diagnosed with kidney failure at 40. Hypertension runs rampant, high cholesterol, all those things. So these are things I need to know. That's ancestry. That's stuff I need to know about. But then there's some other things that happen that have nothing to do with my bloodline, but other people's heart towards folks, right? So I think we have to keep those nuances in retaining race and research. It can really surveil racism, right? And just look at this. This is just gripping to me. When we did just a search over the summer with my SUMAR students with LDI, and one of the things we were looking at was just the papers that were published. I was just asking questions like, what kind of papers are being published about health disparities. So your purple line here is literally flatly just a search in PubMed using racial health disparities only. Look how many papers you got. Got all of those. Then I said I want to look at racial health disparities and prevention. That's your green line. Then I said I want to look at racial health disparities and intervention. That's your blue line. Tom Levy said it best in one of his articles in '03. He said, look, we've got to move from just simply talking about the description of health disparities to more explanation and intervention of health disparities. And what we're seeing is that the research itself is fitting so closely to just describing. All we want to do is just keep saying this group is sicker than this group. How do we use critical methodologies to get to a true intervention point, right? So again, weird, but I said this to him the first time he saw it, so he's used to it by now, I guess. But it's always weird when you do this and the people are here, right? It's like, it's cool when you're like, I know them, but then they're in the room and they're like, you know. So, but one of the things that I think is so important, and I was reading this book when I was in grad school, and as soon as I saw it, I was like, oh yeah, page 1 dissertation. Because this is exactly what we're talking about. We're talking about those real, those imagined, or those hallucinated trivialities, those little things that you walk by people and they give you that look and you're like, I didn't do anything to you, that's not necessary. Or that moment, like I had won 40 under 40 and I'm all excited and got this national recognition and met, you know, Congresswoman Barbara Lee and Congresswoman Robin Kelly gave us the award, all this good stuff, and I'm excited. I come back to work the next day with my suit on. I woke up early, went into Blockley Hall to hit the little 12th floor in Blockley, and I just remember this woman as I'm reaching for the button, just jerking her purse and jumping halfway across the elevator like I was just trying to abuse her or something. And it was that, I don't know what it was, but it was that thing that set me off. Like I went to my office, I sat down for probably about 5 minutes or so, and I couldn't even do any work. I called my friend, she's this dean over at the Du Bois house. I just was like, I just need to talk. And I went over there and I sat there all day long because it just upset me that this is how you treat me, right? I can go to work some days in certain spaces and not speak to a soul because nobody will speak to me. And we have to think about culture. We have to think about that. It's that moment of stuff that doesn't really seem significant that builds up in you. And physiologically, it can change you. And my argument is that we have to have a stronger biopsychosocial model to start talking about those little moments that most people don't think it's that meaningful, but it could ruin your whole day. And the same thing could happen to you, you know, on Friday and it doesn't bother you, right? So my argument is that we have to have interventions that deal with our patients so they know how to deal with this stuff so it's not taking them out, but also interventions that deal with our clinicians. But then we need some other policy level interventions because it's time to start having real conversation about the appropriation of resources and where they're going and not going, right? And that's kind of what this biopsychosocial model is hitting at. You know, I'm trying to use heart rate and compare because heart rate variability, everybody's got an iWatch now. We got wearables and these Fitbits and stuff like that. If we can connect heart rate to cortisol and blood pressure, which are the two main things people connect physiologically to stress, if we connect those things and show that they're reliable and valid methods to kind of be a proxy for stress, and then we look at kidney disease progression, for instance, because that's still highly unexplained. Black folks are 4 times more likely to develop end-stage renal disease compared to their white counterparts. Stress is a heavy associator with end-stage renal disease, but for whatever reason, we haven't found a good way to capture it. So that's what I'm proposing over the series of, you know, even the K Award I'm working on now and the other things, you know, and that's what we've been doing. So I've been so fortunate to get some money so I don't have to beg all the time, Dean Jackson. I stopped emailing them because I got money now. So, but it's a blessing because you're finally in a space where you can do those things, right? So I got the Robert Wood Johnson New Connections Award where we're actually, you know, able to do the data research that you just saw with the CDC work. We got a VA pilot that just finally went through and improved. Their IRB is like, just punch me in the face. Like, just get it over with, you know. But anyway, so we're through IRB, we got that. And then we also had a pilot award where Ezekiel was a PI on that one with the Office of Inclusion and Diversity over in Penn Medicine, where we did an evaluation of the pipeline program. So I can't wait to actually really do a talk on that report. That's really one of the things I really want to do too, because we found some interesting stuff right here on this campus. So, so just real quick, some study stuff that we're working on. So it's Chubb Rock. His mother passed we started this journey, and his mom passed of breast cancer. So he called me right before this talk. He's been dealing, you know. It was rough because it was a quick diagnosis and death. So he's still, but we're working to do this and start talking about translational ways to talk about this research. Oh yeah, my bad. Chubb Rock is a rapper. He's now a radio host, syndicated through Radio 1. He's based out of Atlanta. So we've been working on this documentary. We just got more folks added on. We're interviewing not only celebrities, but we're trying to really assert this idea of how institutional racism surfaces in our health. But remember, I'm not just blaming racism for everything. Now, there's some stuff, we got to start pushing some plates away. We got to start exercising. I'm not blaming doctors either. So we want to provide a balanced approach in a conversation similar to the 13th documentary, but really more one like 13th, but dealing with health. So we got some really great spaces and things on the horizon for that. The other piece that actually will go into Robert Wood Johnson shortly, who cares about just telling people who's sick, right? Why don't we start having conversations with our kids earlier? Because I went to the dialysis clinic with my mom. I saw the stuff that went on. At 10, 11, 12 years old, I saw people getting wheeled out dead at a dialysis clinic. So I know what time it is. I understand that. So one of the things we want to do is also tout and create a youth chronic disease prevention program. And we've partnered with the NFL alumni to do so. And again, a great opportunity. Sometimes doing critical methods is just doing what everybody else is not doing, right? So this is about validating a health literacy program for kids based on a lot of the issues that attack their own communities. So we want to talk to them in their language and use famous people to say, get right, let's change some health behaviors. But we also want to empower them as health coaches to talk to their families. We want to actually foster a conversation about family health history. That's a very important thing that unfortunately for so many kids, you know, for me, my father and his side of the family, I don't know that side very well. So here I am at 36, not knowing the whole other half of me, right? So why not have these conversations at earlier ages with kids while hopefully they're still around so they can at least get something so when they hit that 30, 40 range, when stuff starts happening, when you're pouring milk and your back go out, you know, when stuff starts happening, people are like, is this a family thing? You can actually say, yes, I know it is, right? So we also have the color study, which is collecting observations and lessons on race and racism, where we're actually talking to physicians of color here within HUP. So needless to say, all this money we've been getting has been very helpful because I have now 5 different RAs working on these projects. So I've finally been able to go to sleep at night, you know, longer than 2-3 hours. But, you know, we're going to start these interviews as well to start talking to physicians of color. So Megan, get ready. Yes, yeah, get ready. That's why I shouted you out. Jerry Johnson's working on this with me too, so we're gonna try to. And then the last piece is this app. So this goes more toward my KO1 award that I'm working on. And really what this app is about is trying to connect the stress stuff that we talked about. Using heart rate variability. If your heart rate goes up a little too high, we send you a text. Hey, you okay? If you say no, then we have a series of checkdowns, and that's the kind of stuff we're trying to really get. We're doing so. A part of the CHIRP, that VA funded award, is really talking to patients living with chronic kidney disease within the VA hospital about their experiences of race, racism, and psychosocial stress. So asking them, how do you deal with it? What do you do? Do you go somewhere? Do you talk to somebody? What do you think we should do when it happens? Like, what are your ways to check this stuff down? Because if you don't start having conversations or just even about how you respond to racism or stress or whatever, I think a lot of people are just ill-equipped to deal with it. So we just immediately shut down because you think you're the only one. So with that said, I am 4 minutes over the time I had allotted for myself, but I am actually done. So if you don't have any questions, I'll be happy to help or talk about it. Thank you. Yes. Oh. You go ahead. I'm sorry. I saw your hand first.
So thank you for a wonderful talk and for some very provocative statements. I'm curious about the variability in the manifestation of psychosocial stress and if you are able to identify folks that cope particularly well. And if maybe that might be a target for understanding some interventions. I think the biofeedback has a lot of promise, but I'm also wondering, in that presumed bell curve of folks that cope really well.
Right. So one of the measures that we're using is the index for race-related stress by Sean Utsi, as well as the everyday discrimination. I always say racist. Everyday discrimination scale, because we're trying to also understand how people cope. So we want to be able to stratify folks, but we also, one of the crazy things about the everyday discrimination scale, not to be confused with Krieger's, a lot of people use it, but it's kind of like, and then what, right? It's one of those moments. So I'm trying to understand how people cope, what their experiences are. Is there some kind of translation between the scale and cortisol? Because some people may, again, stuff doesn't bother them the same way. Physiologically, it won't ruminate the same. It may not show up the same way we think. So really what I'm doing is a series of studies that only speak to those vulnerable groups. So we got dinged a lot in the grant review process. We ended up getting the funding, but the reviewers were like, well, why aren't you comparing this, these experiences to whites or something like that? And I'm like, that's not who we're talking to. A part of critical methodology also means that white folks don't always have to be the reference group, right? Because this is not a conversation that we're really talking about, how whites handle psychosocial stress dealing with race and racism. Because we can save the gift card. We can give that gift card to somebody who's gonna talk to me about stuff they're dealing with and find better ways to create a baseline. So that's the uphill battle. So part of this is working with Dr. Norman Anderson. He's one of the co-authors on that Clark paper that happened years ago. And even he said to me, he was like, we have to start thinking about how we put people in buckets according to how they deal with and cope with psychosocial stress. So I'm gonna go here and then here. Yes.
Almost a way that that's being used to justify a white supremacist framework, but also it's historically been the basis of a lot of political solidarity. So I was just wondering if you thought about that in the way that you're looking at it.
I have, and the problem within this CDC data, once you pool 4 million people, only 230,000, 35,000 actually answer the congruence question. So it makes it hard. So when you start getting deeper into the cell sizes, East Indian folks are lumped into the Asian category, and that category is so small that we don't even, once you start, you cut it up one time and then throw in education, you've probably lost, out of the 25 people that answered the question, you've lost half of them. So that's been the biggest issue. So that's why when we did the congruence paper, we had to drop education out because we lost, out of that 94 white that looked black, we lost probably 30, 40 of them. So we had to figure out one was do correlation tests and all that between income education. But the literature's also proven that the education variable is a little faulty with income. But that's still something I think you could explore, but you just have to descriptively explore it versus trying to do something inferentially. Yes.
I just wanted some clarification as to how the three graphs that you showed us kind of relate.
Mhm.
with chronic kidney disease, it seemed like chronic kidney disease kind of very independently of race. So black and white people with chronic kidney disease have like a higher psychosocial stress level. And then finally, like appearance also, like if you are perceived as white or perceived as black, you tend to have some of like the social benefits of that. And I was trying to think about sort of how those three are put together in terms of the cohesive theory on how stress interacts with race.
Definitely, and I'm glad you said that. So for those who've seen me present before, you probably noticed I haven't done that this time. I always do it in any other talk. The reason why is I just like the data talk this go round. Because usually I don't show all the numbers. I kind of give the money shots and then give the theoretical pieces. But this time I really wanted to go through the stats to give that because I like the fact that you can think through it this way. So now here is my overall. My overall is this. The literature tells us heavily when it comes to asthma, chronic kidney disease, diabetes, heart disease, that there is a strong association between stress and diagnosis with that disease, and there's a strong association with progression to end-stage, worse outcomes, those types of things with stress in those diseases. So effectively, one of the things that we know, if you set that aside, independent of race, a lot of folks aren't willing to dig into that race stuff. We just hypothesize it all the time without actually accounting for it in our methods. So what I'm trying to do is finally give a space to, one, corroborate the fact that we know there's a relationship between stress and the chronic disease outcomes that we saw, but more importantly, there's a relationship between race, stress, and those chronic disease outcomes. Because overall, if we know that it's just not giving me some medicine or just making sure I come to the doctor, we have to start thinking about other ways to intervene for these groups of folks, right? And I think those intervention points are things that we forget about when we think about stress itself. When we think about how we handle stress or not handle stress. When we think about the fact that, do we find every racially incongruent person and say, let me help you, right? Is it really one of those moments, or is this really a thing where we have to sit back as an institution, being the United States or the globe, thinking about this incongruence issue and asking ourselves, what can we do structurally? Structurally, what changes do we have to make? Because most people don't believe racism exists, unfortunately. So when I show these numbers, I'm already priming it up to talk about racism, and a lot of folks are just like, well, your sample size is too small, so whatever, you know? So we're having to deal with kind of putting our backs up against the wall. How do we use the data and the methods that are available to tell the story of stress killing us faster, even compared to those who have the same disease, right? So that's really what I wanted to say overall, is that I believe that there's a biopsychosocial process that we have to start acknowledging, that in that biopsychosocial process, that for those who are studying issues of sexuality and other isms, they should be captured in this biopsychosocial process that includes stress. Yes.
So to summarize, it seems like you're proposing that there's like a two-way interaction between stress and chronic disease. Stress can engender and make chronic disease worse, but chronic disease can also create worse stress appearances, which again would make chronic disease worse. And that's all mediated by perception of race to some degree.
Well, not mediated, actually, it would be moderated by that, but yeah. But overall, I think what we're really trying to get people to see is that it's a complicated, I don't want to just say two-step, but it's complicated, right? And I think if we find what we have to do in this, and this was my problem when I first got here. And I'm gonna be honest with y'all, and this is what I was saving to the end anyway, but when I first got here, I was struggling. Because I was trying to think through this, and I'm in the room with some of the smartest people in the world, and they were nice. I'm for real, I thank y'all for being nice, but nobody wanted to say like, dude, you're trying to do too much. You know, and it took the reviewers to just finally blatantly, because you know, they don't have feelings, so they just was like, look, I'm with you, but you know, you need to change all of this, right? So what I had to do was resize it to just focus on that small relationship between race, stress, you see what I'm saying? So that can build the evidence, and that's what this is, man. Unfortunately, it's like, it's hard because you have to, you know, you got to slow walk it. We know where we want to go, you know, and that's what I've always said. Exactly what you're saying. I think it's a two-step process, but, you know, on paper, we have to equivocate and, you know, kind of pull it back a little bit. And I'm learning that now. Like, yes.
Following on to this interesting question, have you thought about doing some qualitative work to try to disentangle that?
Exactly. So the rest of this year is all focused on qualitative work. So we have the VA study, the color study. One of the biggest reasons why I wanted to do this, and another one of the reviewers, right? you have no experience in qualitative research and you're asking us for money to do it. And it's like, how can I get experience if you don't give me the money, right? Because we're trying to prove this qualitatively, you know. So we're using the evidence from these papers to say we need to dig deeper. So that's kind of the other space.
Well, 'cause I think it's really ripe for mixed methods approach, the whole set of problems that you laid out.
Yeah, definitely. Thank you. Thank you. You make me feel good. I feel like I'm in the right direction.
I do. I think it would be really fruitful.
Yeah. Thank you. Yes.
Hi, thank you for your talk. I have two separate questions, and I also straddle medicine and social science. So one of them is coming from my background in medicine. Do any of your current studies use EMR, electronic medical records,
No.
as the outcome data, and how do you feel about using that?
We'd love to do that. But one of the problems that we're having right now is like, again, we have to just prove the first part, right? So it just seems, again, it seems like somebody would have done it already, but actually, particularly in the CKD, kidney disease space, it has not really been talked about in this type of way.
So I'm interested a little bit in how EMR propagates the three types of racism and actually maybe isn't objective data. And I wonder if in your space people are having that conversation or if they view it as highly objective. And it sounds like it's still pretty objective, sort of considered. And then my other question was about coping and researching who's a particularly good coper and advocating for coping. Have you gotten any pushback that it's still a disparity focus, not an equity focus when you look at coping and making people better copers? Like, did you get a victim blaming pushback that it's on the folks that are being impacted by institutional racism that they need to cope better with this as a solution? How has that conversation played out?
It's played out interestingly. So one of the things, my office is actually located in Blackley Hall, which is the School of Medicine. So I'm one of the very few on the floor non-clinicians. So when I do my talks, they just like, so imagine a little over a year ago today was when I moved over there, just like lived there. Everything still comes from SP2. So imagine me doing this talk, much more radical. I'm all over the top, right? And all the physicians in the room went from leaning up like, wow. So I started seeing the arms fold and they lean back like, so I have questions, right? So once you start going through that, the hardest part of this process is getting really good constructive criticism. And that pushback has always been two things. So you're telling me you have to tell people how to basically subvert racism. And I don't like that. And I said, well, we have to have the talk. My mom had to have the talk with me. My mom told me when I was young, don't you ever leave a store without a bag because they'll accuse you of stealing. So what's the difference, right? So we have to acknowledge the fact that we can't just sit here and say, in a perfect world, snap your fingers, we don't want racism here anymore. No, I've got to talk to the people who are providing care. I got to talk to the people who need to get care. We have to have different conversations. And one of the things I've had to learn is to explain those different conversations explicitly, right? To be able to say, I'm not explaining this to patients how to deal with stress of racism and then say, if you don't deal with it, it's your fault. No, I'm saying this is one step that we have to do. We also have to talk this the incongruent space with health care. Because what we've seen is that white folks who look black, actually, particularly white women who look black in this, one of the other studies I didn't show, they actually have the lowest probability of getting cancer screenings compared to those who are racially incongruent, or racially congruent, right? So we're seeing differences and deviations in healthcare among perception of race. So these are things, again, like it becomes harder when you do these kinds of presentations to, you know, as he pushed to kind of get me to give like my grand theory theme or whatever, it becomes harder because you want people to chew on it. You want people to just take what they saw. I don't want to influence you, you know, in a way. I just want you to see the data and just sit back and let you think on it. So it's still, I'm still finding my voice on that, but yeah, I appreciate your question. Anything else? Yes.
How do you balance your identity as a scholar with your identity as an advocate? And how do you publish peer-reviewed literature with its focus on incremental gains and still maybe try to engage the public? I know you're active on Twitter.
Yeah.
How do you sort of find that balance?
It's hard. You know, the breakdown moments come a lot. you know, to be honest with you. I mean, you know, I've won more. I feel like the awards I've won, I don't deserve yet because I'm not there, you know, because I want to be a full professor and be, you know, have all these papers and all this stuff. But Tom Levy said it best. He was at Hopkins, now he's the chair of health services at George Washington. But I had this talk with him not that long ago, and I was just like, I'm struggling with this, you know, like, what do I need to do to like still be productive but be impactful? And he's just like, I mean, even I've published stuff that I know, like, this is what I have to do to get the academic side of life. But then there's another path that we also have to take, and that path towards activism and academics, they don't always go together. And unfortunately, for the last few months, I've just had to keep my head down and do this, right? So it's like I've said no to more talks than I've ever said in my life, but I have to, because this postdoc is coming to an end, and you can't come to the end of this at a place like this saying, you know, I'm a great speaker. I know that, you know. So now we got to publish, and it's hard. I mean, I'll tell especially a lot of the students that are here, like, you know, most of you feel like you're going to get your degree and that's your ticket to say and do whatever you want. But really, it just gives you a different audience, right? So you have to just remember, like, you don't leave here with everything. All it's saying is that you've gotten to a certain level, you've done certain things, and that doesn't mean you're done. It just means you're just getting started, but you're starting from a better place than a lot of other people. And that's, you know, when I interact with so many students, they feel like, you know, here's my great example, and this is what I told my class last week. You know, I had this big old coat that I bought when I was 19. It didn't fit me then. It fits enough now, but I just thought it was cool because it was $20 in Marshalls. It's like a ski jacket. And I had no need to wear it until I got here, apparently. And, you know, I remember when I was defending my dissertation, I had to come to this room. Dean Jackson, I know you and Ezekiel remember when I had to do in this room to kind of present my research. And I remember getting on a plane in Orlando, and I had this big jacket on, and this dude was looking at me like, and we were in the terminal area or whatever, and he was just looking at me like, where is he going? Because we're in Orlando, it's hot. And they looking at me like, where is he going? You know, and in my head, I think about that often because in this work, you have to dress and prepare yourself for where you're going and not where you are. And the thing that I hurt for is I know where I am. I know my speaking can be great. I know my presentations can look great and all this, but I had to retool a lot of stuff because this is cool for now, but where I'm going, you gotta be ready for that. You gotta be ready for people like, I can come, this is a friendly audience. But when you go to those non-friendly audiences, you know what time it is. People are coming at you. So I'm telling you as students, put the big coat on now. Like, stop complaining that we're giving you too much work and all this kind of stuff. That's the nature of the beast. We're preparing you for where you're going, not where you are. You know what I mean? Like, that's the thing that I believe is the most impactful part. So